made it.
Oh, we did make it. But where's everybody else?
Can you see us, Dr. Palmer?
Oh, now I can see you. Yeah. Oh, I guess I only see you talk.
So we're just going to give people just a couple of seconds to log in. You can see everyone's logging in down there at the bottom.
Mhm.
And so we'll wait just a second so that people can get logged in. Then we'll go through housekeeping and get started.
Okay.
So while everyone is logging in, I just want to thank everyone for joining us this evening. My name is Brooke McGivern. I am a speech pathologist and the Director of Marketing and Communications here at Tim's Medical. And we have with us this evening, Dr. Phyllis Palmer and Aaron Padilla. They are going to be presenting on the BOLUS Framework. So we are extremely honored and excited to have them this evening and excited to have you all present with us. Just a couple of quick housekeeping items for those of you interested in obtaining ASHA CEUs. We do ask that you stay for the entirety of this presentation. However, if it does go over the 1 hour mark, feel free to log off if you need to. We will record this webinar, so if you miss any information, you can always catch it on the replay on the website tomorrow. And to obtain ASHA CEUs, we ask that you complete a survey that we do have available on our website. It'll be sent out via Zoom emails, and I will put it in the chat during the webinar. And if you have questions, feel free to pop them in the Q&A box or the chat, and we will go through a Q&A section at the end of the webinar. So with that, I'm going to hand it over to Dr. Palmer. But if you all have technical questions during, feel free to put it in the chat and I can answer that as well. All right, Dr. Palmer, I'm going to make you the co-host, or make you the host.
Okay, and I'm going to share my screen. Does that look correct, Brooke?
Yes.
Okay, all right, thank you. And I am going to turn this over to Aaron to get us started.
All right, so hello everyone. This evening we're going to be talking about the BOLUS Framework, a theoretical clinical tool for identifying the odds of adverse events presented by Dr. Phyllis Palmer and myself, Aaron Padilla. As we get started this evening, I do want to just offer a quick thanks for everyone sharing their time with us this evening. Thank you for Brooke and the Tim's team for inviting us for the talk. And then also just a quick note of thanks to Brooke, Tim, Tony, everyone at Tim's for just this great educational endeavor, Tim's University. It's been a great event this year, and thank you for just prioritizing patient care and improving outcomes and everything you guys do. So next we have here our disclosures. And the agenda for this evening, we're going to discuss what happens when an individual aspirates. We're going to talk about host defenses and individual differences, immunology and pulmonary defenses. We'll talk about the BOLUS framework. We'll apply this to a couple case studies, and then we'll have time for questions. Throughout the slideshow tonight, we have a QR code with a couple handouts for everyone. So we have it here in the middle of the presentation at the end. So as we're discussing adverse events secondary to swallowing impairment, there's a range of outcomes that can be aspiration pneumonia, sometimes called hospital-acquired pneumonia, community-acquired pneumonia, nosocomial pneumonia. We can have aspiration pneumonitis if you have a aspiration of a chemical such as gastric contents or highly acidic contents. You can have an adult onset of pulmonary disease such as asthma. You can have an exacerbation of current respiratory disease such as an acute exacerbation of COPD. You can have other medical complications such as frailty, malnutrition, or dehydration. Think of the patient that's maybe chronically on thickened liquids and they become dehydrated. And in the severest of outcomes, we can have death. So as we're talking about host defenses and individual differences, we want you to think about primary defenses, those defenses that occur before the invasion or aspirate make their way into the lower airways or the lungs, and then secondary defenses, those defenses that the host employs once the aspirate is in the lungs. So this was originally proposed by Dr. Michelle Trochet and her group on a framework for understanding the shared neural substrates of airway protection. So we have swallowing first, the larynx moving up and out of the way. You have glottal stop or laryngeal adduction reflex, the glottis closing during swallowing. You have an expiratory reflex. Think of your swallow-breathe pattern of a typical swallow-breathe pattern being exhale after swallow. You have expiratory effort, the amount of effort or robustness to clear the airway of any invasion. You have a reflexive throat clear or a reflexive cough. These can also be cued if the patient has suboptimal sensate response to any invasion. So we discussed prevention, and then now you had ejection. So next we have a partial or failed airway protection. So you may have a dystussic individual who has a weak suboptimal cough, or maybe they're able to eject some aspirate, but not all of the aspirate completely. Maybe they eject thin liquids and not more dense materials such as puree or a solid bolus. Maybe they have a weak cough and no ejection at all, or maybe they're atussic where they have no cough despite any stimuli. And there are some data noting that this can vary depending the volume of the aspirate. So as we started this evening, we talked about primary and secondary defenses, and now we're going to detail that in more greater fashion here. So this is the elimination cycle. So we have constant immigration into the lungs that helps facilitate the pulmonary biome. Think of nocturnal aspiration of saliva. You may have micro or macro aspiration from swallowing impairment or dysfunction. Now the host has innate defenses to aid in elimination. So we talked about the primary defenses of cough, reflexively or acute cough, and throat clear. We also have the secondary defenses of, or excuse me, those were the primary defenses. Now the secondary defenses, once the aspirate is in the lung, you can have aquaporin absorption, where water is pulled from the lungs into the capillary and then voided out of the individual. Think of a water protocol or a bronchoalveolar lavage, where water is instilled into the lungs. Those patients generally don't have any adverse events if the water is clean and oral hygiene is adequate for the water protocol patient. You have a mucociliary escalator, which generally functions adequately for patients without pulmonary disease or smoking. This occurs when a small amount of mucus is attached to the aspirate, and then ciliary small hair fibers work on moving the invasion up and out of the lower airways, and then with the cough or throat clear throughout the day, then that's cleared out of the airway. And then we also have phagocytosis, which is a part of immunology. Think back to your college biology course, where this will aid in an immune response in engulfing and clearing the aspirate out of the lung. And with that note, we'll have Dr. Palmer discuss that further.
Hi. So you aspirate. What happens when the primary defenses don't work? Well, elimination is unsuccessful. You end up with material in the lungs, and the bacterial pathogen injures the lung tissue and triggers an immune response. Right? This is, so cytokines are released by the damaged cells, which serve as a signaling to proliferate cells and bring appropriate cells to the impacted area. The cell proliferation is identified as inflammation, which localizes to the insult or where the aspiration occurred. In addition to the immune response, the other secondary defenses that Aaron just talked about take place, such as the mucociliary action. The immune response and the physical response serve to eliminate the invader and repair the lung tissue. But it can also lead to complications if the inflammation becomes severe or prolonged. This can happen in repeated aspiration. So when you have repeated aspiration, the healthy inflammation response of the immune system leads to chronic or excessive inflammation. When cytokines become overactive or upregulated, it causes the immune system to basically attack itself, and this leads to worsening of the inflammation. In addition, there is a change in the membrane permeability, so you end up with more edema in the lungs, and as a result, the lungs do not oxygenate well. This can lead to increased growth of capillaries to try and compensate for the poor oxygenation. And poor oxygenation can also impact the swallow timing by messing with the required respiratory cessation duration. So recent data also links this chronic inflammation to systemic loss of muscle mass, which is kind of interesting because then that increases frailty. Also, chronic inflammation leads to lung damage, and the body may not be able to repair it with the normal immune response. So the permanent lung damage translates to respiratory disease or exacerbation of a previously diagnosed respiratory disease. The presence of frailty and the respiratory disease increase the dysphagia, which then leads to greater amounts or more amounts of frequent aspiration, thus worsening this inflammation cycle. So the cycle just continues to perpetuate. Now, As speech pathologists, there's no clear method to assess the level of inflammation in our swallow eval. There are some nonspecific markers of inflammation, such as C-reactive protein is a popular one, white blood cell counts, particularly with a differential, so we can see how many neutrophils and other cytokines that might be present, the presence of fever. Procalcitonin is considered to be a little bit more selective because it implicates bacterial infection. However, there is some data suggesting that procalcitonin may be misleading in critically ill patients, which might be a lot of our folks, right? Sensitivity and specificity of these measures, specifically to implicate lung inflammation, is very limited. However, when you combine these with other observations, they may help support your hypothesis. So the question becomes, how do we as SLPs assess risk? So I have to introduce you to one of my friends. This is BOLUS Man. So BOLUS Man says, in the presence of aspiration, clinicians are urged to focus on the risk factors that can lead to a negative consequence, determine which factors are modifiable, and determine when a level of risk is acceptable. So how do we identify these risk factors? So we developed something called the BOLUS Framework, and guided by the previous framework described by Dr. Ashford, you might remember he had the 3-pillar framework. We developed a framework that evaluates risk of an adverse event as a function of 5 risk categories. So we have bolus variables and the response to aspirated boluses, oral health and oral care, lifestyles and activities of daily living, unintended or iatrogenic risks, and system status or general health. So within each one of these risk categories, we have subcategories. And I'm not going to read them all because these are all in your handout, and you can get that handout from the QR code. But so, for example, under bolus and response, we have, what was the pH of the bolus that was aspirated? What about bolus viscosity? What about the amount or how often? How deep did the aspiration go? And what was the response to the aspiration? So we tried to identify the subcategories here. And then for each subcategory in the under each bolus framework category, we also have questions that align with the subcategories. And we're going to review these in more detail in the next couple slides, so I'm not going to read them all here. This is just an overview. And again, this image is also in your handout. So what has been done so far? The question we're going to look at now is, what have we done so far to evaluate the evidence to support or not support this bolus framework that we've proposed? So we did a rapid review and identified 16 studies that addressed the variables noted in the bolus framework. For each study, the level of evidence was assessed by reviewing the statistical level, the population, like was it done with humans or animals, and the study integrity, like was it a randomized control or what kind of study design. Using these variables, we identified if a data point was conclusive, and you can see that this over here, conclusive, here's our definitions, suggestive, unclear, or not supportive. Then across all the data points that we extracted from the 16 studies, we sorted the data by bolus framework question and outcome. We included only data that assessed 3 possible outcomes, either a pulmonary outcome, which means a new pulmonary event like aspiration pneumonia, or a new pulmonary disease, or an exacerbation of a current disease. We assessed survival, did they live or not, and other medical consequences such as fever, UTI, increase in frailty, or malnutrition. Once we sorted the data points by the bolus framework, we assessed the evidence for each given question, remember these questions back here, for each given question, and identified the evidence as either, and you can see this over here, as either strong, moderate, insufficient, or negative. And then we combined the rating for each one of those individual things to see for each question, how do we assess it? So if you want to get more details on the method, because I don't want to spend too much time on that, this is all published in open source in Frontiers under a rapid review. So, and the link is in the reference list that's in your handout. So what did we find from this review? For the B questions, is my patient aspirating thick or dense materials? Is my patient aspirating frequently or aspirating large amounts? Is my patient aspirating acidic material? Does my patient have a weak cough or silent aspiration? Those were the questions we looked for information on. We found 12 data points from 6 articles, and it addressed 2 of those 4 questions. And so for thick and dense, we found conflicting data to link the aspiration of thick and dense material to pulmonary or survival adverse events. And we found a strong link to other medical adverse events when there's aspiration of thick or dense material. For frequent and large amounts of aspiration, we found moderate support linking frequent and large aspiration to an adverse event, but the outcome wasn't specific. Sometimes it resulted in pulmonary, sometimes it resulted in survival issues. We did not get any hits on acidic. However, recently we just finished a systematic review for this and presented it at the last DRS, which was in beautiful Puerto Rico. And we found insufficient evidence linking the risk of death to aspiration of acidic contents. Yet there was moderate evidence linking the aspiration of acidic content to an increase in pulmonary disease, pulmonary complications, and other medical complications such as fever, malnutrition, and that kind of thing. So now let's look to O. So O, the questions we have under O: is there evidence of oral neglect or poor oral infection control? Does my patient have inadequate oral hygiene routines, or maybe a recent change in their oral hygiene routines? Does my patient have reduced saliva? And we found that we got 13 data points were identified regarding oral care and oral health. And there's strong evidence noting that if oral health is poor, there is an increased likelihood of a pulmonary sequela or some general medical complications. There was insufficient data regarding the risk of death with oral care and oral hygiene. So one point to note here is that for oral care to be considered adequate, there must be friction and there must be a debriding agent. So basically toothbrush and toothpaste, right? And there must also be some rinsing or suctioning. And so those pink sponges that some people use don't really amount to oral care or oral hygiene. If you're looking for more information on oral health and oral care, Dr. John Ashford just published a super duper amazing review paper on oral care and the impact on dysphagia. And that is an open source document that's available through Frontiers. If you need the reference for that, just email me and I'll send it to you. It's a great paper. I'm going to turn this over to my most excellent colleague, Aaron, and he's going to walk us through some more of this. Thanks, Aaron.
Speaking of walking, let's talk about level of mobility, lifestyle, and ADLs. So does my patient have limited mobility or physical activity? Does the patient smoke or drink with regularity? Is the patient dependent on others for activities of daily living, specifically feeding or oral care? Can we go to the next slide? Within the rapid review, we had 3 studies with an insufficient level of evidence. The evidence that we did find was for lifestyle and ADLs, most notably the seminal Dr. Langmore 1998 and 2002 paper, showing that individuals that are dependent for feeding for oral care have a greater likelihood of adverse events. In her 2002 paper, patients that were bedbound or bedfast had a higher likelihood of adverse events. Within this, we want you to think as we get closer to the case studies of, are these factors modifiable? Are they non-modifiable? Were they mobile at baseline, but now maybe they're bedbound because they're deconditioned in the hospital. Another factor to consider is current active smoking, not detailed in the rapid review, but we discussed mucociliary clearance earlier this evening. For patients that are currently smoking, that the ciliary function will be diminished and not as optimal as an individual that's not smoking. Next, we'll move on to unintended or iatrogenic disease. Does my patient have a feeding tube or tubes of any kind in the aerodigestive tract? Is the patient receiving mechanical ventilation? Is the patient on any medication that may impact alertness, cognition, immune function, or saliva production? Does the patient have any side effects from radiation or other medical procedures that impact the oral pharynx? Now, within the rapid review, we had 3 articles with 3 data points that answered one question. And this question was tubes within the aerodigestive tract, so nasogastric tubes and trach tubes. One study identified that the greater the duration of nasogastric tube presence, the increased likelihood of pulmonary events. Also, some data out of Dr. Nativ Zaltzer's lab looking at the frequency or the patients that have a trach tube have an increased likelihood of pulmonary events. There's insufficient evidence to determine the relationship between the presence of tubes on survival and other medical complications. We do want to note that for the patient that is receiving mechanical ventilation, there will be a dysbiosis of the pulmonary microbiome. And if you're looking for more work on that, you can look to Dr. Robert Dixon's work. He has a lot of work on the pulmonary biome. Lastly, within the BOLUS framework, we have S for system status. Is the patient frail or deconditioned? Are they in poor general health, or do they have a compromised immune function? Do they have multiple comorbidities, specifically GI disease or pulmonary disease, or do they have limited or declining cognition? Within the rapid review, there were no data points for extraction. Some things for consideration: if the patient has GI disease and there's an increased likelihood of extraesophageal reflux, laryngeal reflux, aspiration of gastric contents. Does the patient have maybe esophageal dysmotility or structural anomalies where the likelihood of retrograde aspiration in a recumbent position increases? Does the patient have an underlying respiratory disease? Are they on supplemental oxygen chronically? We discussed the Nativ Zaltzer paper earlier, and they also found in that paper that patients with chronic kidney disease had a higher likelihood of adverse events. And something that Dr. Palmer and I have been thinking of more is there a role for cardiac disease? There are some data on patients with hypertension having an increased likelihood of small subacute strokes, and one may postulate, does that increase the likelihood of micro aspiration? Also for consideration would be patients that are on any immunosuppressive medication, such as high-dose steroids, if there's any systemic therapy, such as chemotherapy, or if they're on any immunosuppressive medication post-organ transplantation. So now, as we're moving to our case studies, we have a representation of the BOLUS framework. So as we're discussing the couple cases that we have prepared this evening, sort of think of these questions that we've proposed earlier and looking at, are these things that are chronic and we can't change and they're non-modifiable? Are these things that are acute and maybe with support we can modify them? How can we sort of balance all of these factors and details, and what changes can we make as a swallowing clinician to help make the most optimal outcome for all of the patients that we serve? So as we move into the case studies, you are asked to evaluate a 75-year-old male with a history of atrial fibrillation and hypertension, secondary to nursing staff reporting coughing with oral intake. There's concern for dementia. He has excellent family support. He's ambulating in the hallway with a walker. He can complete activities of daily living independently. He just needs occasional support or reminders to complete oral care, and as a result has suboptimal oral hygiene. His BMI is 24, so within normal limits. A FEES is completed, noting an efficient swallow for thin and mildly thick liquids, puree, and solids. There is a consistent penetration aspiration scale score of 7, so aspiration with a cough that was unsuccessful in ejecting the aspirate, with thin and mildly thick liquids that was refractory to compensatory measures, and this patient has no history of pneumonia. So next is you consider what factors are salient and important for determining risk. We have a few of those highlighted here today that we'll discuss. So we discussed the cardiac disease a few slides earlier and the implication of that. And then as we conclude the case study, we'll talk more about the cardiac disease and measures we need to take before implementing some of our tasks that we have. The patient coughing with oral intake, we can, speculate after our instrumental examination that maybe this is a frequently occurring thing. There's concern for dementia, no diagnosis officially, but if the patient does have dementia, we are going to see a decline with time. Excellent family support. So even though he does have dementia, we can maybe modify some things and have more support and implement some things that he may not remember on his own. That he's ambulating in the hallway with a walker. This is advantageous for pulmonary hygiene, pulmonary clearance, and a lot of data out of the physical therapy literature looking at days of mechanical ventilation decreasing when patients are mobilizing. So this, although not on mechanical ventilation, this is something that may facilitate pulmonary clearance and may speak to why this patient has not had any adverse events. With the oral care, I would say that that's a modifiable factor. He's in a healthcare facility right now, so we can ask our nursing staff colleagues to assist with implementation of oral hygiene. We can ask occupational therapy to assist with this, and then of course family as well. Let's see, we also have a BMI that's adequate, so the patient's not frail. He has an efficient swallow. It sounds like just safety is our concern. So maybe in the chat, folks can kind of put their thoughts. Is this, someone that you would make NPO? Is this someone that you would keep on a diet? Where would folks, trend with that? And then what we can do is maybe we'll finish up this case study and then we'll pull out a couple of thoughts from folks, as we conclude our discussion. So some things we have highlighted here, with our BOLUS framework, the patient is aspirating thicker, dense materials. We can maybe, through clinical shared decision-making, ethnographic interviewing, find out if there's foods that are maybe very culturally important to the patient. Maybe those are thicker, dense materials. Can we maybe work on, if it's in line with the patient wishes, making those a little less dense? Can we avoid acidic material while the patient undergoes the rehabilitation process? We can work on strengthening his cough with EMST or sensory motor training for airway protection. Although the oral care is suboptimal, we can provide external support to assist with that. Mobility, he's mobilizing adequately. He does need some assistance for ADLs, which we discussed. There's no iatrogenic disease. And then the system status, there are maybe concerns for cognition, but there's no underlying lung disease. So, something to consider with this patient, he's had no history of pneumonia. Maybe, we keep this patient eating and there's some modifiable factors that we can apply. Something, very recently brought about by our very dear friend and colleague, Lori Winterholm, is, can the patient maybe do his EMST after he eats? So if you're doing your 5 set of 5 protocol, you have 3 sets there. And then, as there's immigration into the lung, maybe the EMST can help to facilitate some of the elimination. We're working on strengthening his cough. So something to consider as we move forward. So next we have our second case study.
Aaron, before you move on, I wanted to point out that in the chat, there was an overwhelming response to keep him on a PO diet. Some people mentioned some potential modifications or compensatory strategies, but keeping him on a regular diet with the safest, least restrictive diet. It was kind of the theme here. So, and there was somebody gave a shout out to RMST, and somebody suggested some oral hygiene and engaging the family support. So there were some nice responses in there that I wanted to share. And I apologize because I didn't advance the slides before, but I don't know if you want to speak to this slide and the next slide. You kind of summarized this, but
Let's see here. Yeah, so as we discussed, we have, some red flags there, but many of which we can modify and create a plan going forward to reduce the patient's risk. One note that I do want to mention before I forget, that he does have underlying cardiac disease. It would be helpful to, that he's admitted, say cardiology is consulting We can always discuss with the medicine service, but also running that by cardiology, just to make sure that we, by doing EMS here, not going to cause any iatrogenic effects there. And then, as we discussed, we have our checklist there, and then this is in everyone's handout. I know there was some trouble with the QR code. I updated it, and there it's on the last slide for anyone that needs. And we can go to the next slide. Okay, so we're doing pretty good on time, so we'll have some pause for discussion before we reveal our red and green flags there. So we'll open up the chat again. You were asked to consult on a 60-year-old female living with Parkinson's disease. She's admitted with COVID-19 viral pneumonia. On day 4 of admission, there was an increase in supplemental oxygen needs and coughing with medication administration. The patient is mobile at baseline, but currently bedbound. Excellent oral care and hygiene. Currently, she is on 10-liter Salter and a history of COPD and pulmonary hypertension. Video fluoroscopies completed, yielding with physiologic findings of incomplete and reduced duration of laryngeal vestibule closure, noting a penetration aspiration scale score of 8, so silent aspiration, no cough to eject the aspiration, with thin and mildly thick liquids, with no residue with either of the liquids, or small typo there with pudding or solid bolus. There's further reduced tongue-based retraction and reduced, another typo, we'll omit the reduced tongue-based retraction and pharyngeal compression part. PS of 1 with no residue with puree and solid bolus. So let's go ahead and open up the chat for folks and see, what would your management plan be for this patient? It looks like there is definitely some risk involved. What do we do to move forward with this patient? So we'll need to be considering patient and family wishes, goals, and all of these. This is great. Yeah, wonderful point. And then, yes, let's also add what concerns you see in the history that will guide the management plan. Do we have another thought? What does the family want? Educate on cost benefit. We see some red flags here: Parkinson's, COVID. We have another comment: given the patient's status, would this exacerbate the status of their Parkinson's? Yeah, that's a really good point. If the patient can't swallow their Parkinson's medication, good point, good point. Goals of care discussion, temporary non-oral nutrition, hydration, free water. Occupational and physical therapy consulted, very, very good points. Yeah. All right. So I think maybe we're at a point here. Oh, folks are still chiming in. Yeah, you guys are great. Look at all this discussion. Wow. Wow, wonderful, wonderful. Thank you guys for such rich discussion looking at rehab potential. All right. Thank you guys for such a very rich discussion there. So some red flags, the patient does have Parkinson's disease, a dysphagia causing etiology. Some folks brought up Parkinson's medication administration. At times, you can discuss with neurology or medicine, if the patient can't swallow their Parkinson's medication, maybe consideration of, sublingual administration, or, I believe there's a transdermal patch as well that PharmD can assist with. COVID-19 viral pneumonia, so the lungs are already under some stress. There are some nice data out of Dr. Michael Puglia's lab and Dr. Nicole Rogas-Puglia looking at sort of the inverse of that COVID-19 severity for patients with underlying dysphagia. Nice read there if anyone is interested in that. Oxygen's trending up, so we know that the lungs are under some physiological stress there. Some things that are in our benefit is, patients mobile at baseline, that's great, but currently bedbound, deconditioned, and frail, which is really going to increase their odds of adverse events. Excellent oral care and hygiene. So that's great. Something that we can keep up on. Underlying, pulmonary disease with COPD and pulmonary hypertension, how we talked about the mucociliary clearance before, that's going to be diminished for sure. And in regards to immunology, fighting pretty hard against COVID there. So, this is a tricky case for sure. Let's go to the next slide there. And this is definitely where, BOLUS framework can be an educational tool for the patient and family, discussing cost benefit, what are their goals, some nice resources with that, with the Speech Path Pod with Aidan Osborne and Dr. Sean O'Keefe, really, really detailing that nicely. But we also have to balance, if we make this patient NPO, are we causing something iatrogenically as well by furthering disuse atrophy in a patient that is already frail? So some things to consider, liquids, we're not able to omit the aspiration, great oral care, mobility is reduced. We talked about some folks in the chat consulting OT and PT, deconditioned. But as we go back a slide, we can look at, well, the patient had PAS of 1, so no airway invasion with puree and solids, and no residue. So, think of this as a dynamic plan of, can we in this moment keep this so there's risk, we've identified risk, and if we keep this patient on full oral alimentation, that risk may be at an unacceptable level and it may have a higher likelihood of adverse events. But can we maybe meet in the middle? Can we maybe do, soft and bite-sized diet and ask medicine to consider, IV hydration? There was discussion of water protocol. I don't remember the exact study, but there are some data looking at a couple of patients that were in a water protocol cohort, and it was thought that their demise was secondary to the water protocol. They had underlying lung disease. So that the patient, is trending up on oxygen, maybe we hold off on the water protocol. Maybe they, middle ground is maybe they can have some like ice when they're eating to keep their mouth moist, and we perhaps do a soft and bite-sized diet if they are a candidate for IV hydration at the time. And then maybe pending this patient's clinical course, can we do a repeat video fluoroscopy, or can a FEES be considered? If we can skip the next slide and go to our closing thoughts there. So risk varies. That's a really big point that we want to emphasize this evening. So I'm sure, everyone at some point has maybe had a patient with, say, head and neck cancer, for example. They have a late radiation associated dysphagia, and they say had a video fluoro a year before they saw you, and on the video fluoro they're aspirating, they've had no adverse events. But maybe they, contract some sort of upper respiratory infection, and now they're in the hospital, and now they have a hospital-acquired pneumonia because their mobility isn't reduced, or excuse me, their mobility is reduced. Or maybe they fall and break their hip. Holistically, they were doing fine before and they were managing the aspiration, but sometimes acute illness can either increase the frequency of immigration into the lungs and decrease the elimination of the aspirate out of the lungs. And that could be why, in the head and neck cancer example, why the patient now had an adverse event when they were doing okay. So in that case, in that management plan, we really need to look at the whole picture and see, during these times of acute illness, acute care, acute rehab, can we sort of band-aid the situation in the sense of, be AAA and get this person, safely to the next destination, and then outpatient clinic, we work on rehabilitating things, or metaphorically speaking, them going to the mechanic there. Management is ongoing, and that's sort of the point I was trying to make there, of these variables can constantly change as the patient goes through various aspects of medical care, various stages of life. And that's where it's very important to have an ongoing discussion with the patient, their family, the medical team, to ensure that we're making decisions that are taking into account the patient and family values, decisions that are culturally responsive. And can we use BOLUS framework as a education tool? If maybe you have a patient that they're at very high odds of an adverse event, and based off of your clinical calculation, you feel that the level of risk is unacceptable, you discuss that with the medical team and they feel the same, but maybe a goal for the patient and family is to, de-escalate care, maybe focus more on palliation. And a very nice framework by Marta Kazadijan and her partners framework, looking at, those instances. Can we have, a level of recommendation of, well, given the the very high odds of adverse events and the level of risk, my first recommendation is this. Say, to make the discussion a little easier, say NPO, for example. But given the patient family goals to, continue with oral intake, my second level recommendation is this. So what that would look like is, is the patient open to maybe avoiding acidic things? Are they open to, changing their diet some that would, decrease the bacteria latent contents that are aspirated? If fatigue is a concern, are they, interested and open to, having more caloric intake earlier in the day? So how can we make this decision as a team? The big thing here is really, really focusing that this is a team approach. And just like, the swallowing clinician, the speech pathologist, the physician, the nursing staff are all very important parts of the medical team, but also the patient is a very important part of the clinical decision-making process. And it's really our goal to have a funnel approach of taking the best available clinical evidence, our clinical experience, and the patient family goals and wishes, and funneling that into a decision and a care plan that really facilitates it and supports what the patient and family would like to do. So with that, I think we can open it up for questions. Folks were very active in the chat there, so I imagine that we'll have some great discussion, some great questions. It looks like someone added the BOLUS framework to their documentation. That is wonderful. Thank you for doing that. And that was the goal of this whole framework, is we wanted to create something first off, create something that was fun. We'll let you guys be the judge if we achieve that goal. But second off, we wanted to give a tool that was helpful for the novice, but the seasoned clinician, the physician, the patient and family. We really wanted, and this is available in the handout, our original tutorial right before BOLUS was created. We wanted one paper that if you give this paper to any physician, any clinician, you can say, this is why I'm keeping this patient eating despite their aspiration. This is all of the evidence up to that time, I believe that was 2022, that is supporting, our clinical decision-making. On that note, I do want to add and, chime in as well, Dr. Palmer, is we do want to emphasize that right now this framework is a theoretical framework. This is all based off of, data that's been done before us. We do have some work ongoing on investigating this further and the aim of moving it out of theory. But we do want to, stress that as well. We have a great question here. Do you think that this framework is supportive in pediatrics as well? I'm going to let Dr. Palmer answer that one, because I don't have any experience with the pediatric population there.
Yes, Aaron avoids tiny humans. Currently we don't have the data to do that, to support it. However, in talking to some various pediatric content experts around the country, there is a sense that it does apply. There might be a couple things that might be different, obviously, for an infant's not doing oral care and whatnot, but there is some implications that this might be useful. We just haven't tested it yet. So I will look forward to being able to share that information in the future. Aaron, somebody asked if lots of people are using, I can't find the question now, that everything went so fast. If people are using IV hydration with a non-liquid diet, is that typical? Do people often do that, or how often is that done?
Yeah. That's a good question. So I can only speak to the acute care setting where that's my clinical experience. But if we do have patients that are at a higher odds of an adverse event. We discussed with medicine. In most instances, unless there's concern for fluid overload, if medicine is diuresing the patient, trying to get fluid removed, in most instances they'll say, yes, we can do this. I have heard from colleagues instances in more rehabilitation settings or long-term care settings of subcutaneous is that the term where hydration is injected into the like adipose tissue being utilized for some patients. But I would say, the IV hydration is an option. Sometimes you have a patient that maybe has an NG tube before you get there. And you may do the NG as well, where you can have them an oral diet, but maybe hydration through the NG, or the same thing with a PEG. Maybe you have someone with a PEG tube, you see them in the clinic or in the hospital. They look good with pure air solids, but not yet with liquids. You could do the same thing, hydrate through the PEG as well. These questions are just pouring in. This is wonderful.
Yeah.
I do like that Dr. Grand offered that what's also beneficial is that the framework is useful when implementing shared decision making, which is critical for patient-centered care. Absolutely, yeah, there was definitely a vision of the framework here. Let's see as we go through
And
more.
some people are using it in their documentation and have smart phrases and whatnot. So that's kind of exciting to see. So for those of you who are using it clinically, when you look at it and you're sharing it, oh, and someone else mentioned using it as an educational tool with patients. When you're using it, are you thinking, oh, you wish it had this other question? Or do you feel like there's any area clinically that you feel like isn't being well addressed in this framework with respect to risk factors? I'm just trying to see if there's any other questions. Aaron, a bunch of people are asking for a link to the article on the water protocol.
I will try and
Dr. Palmer, I put it in there already.
Did? Okay. Okay.
Yeah,
Thank you.
so if you all want the article from Dr. Ashford, scroll up in the chat. There's been a lot of conversation in the chat, but if you scroll all the way up, I put it in there for you all.
Oh, I think Aaron also mentioned another article. Is that right, Aaron, on free water protocol, or did you?
Yeah, the one paper where I think there was 1 or 2 patients with lung disease that had adverse events there. I don't know what paper that was off the top of my head.
Was that the
I
one in the long-term care facility?
think it was long-term care, yeah, but I don't remember the authors of that. I can look for that, but I'm sorry that I don't have that off the top of my head.
Was it Murray?
I don't remember.
Okay, yeah, all
Forgive
right.
me, the memory slipped there. There is a question on if the framework is flexible. Yes, it is very flexible. So the work is ongoing on identifying, just to give everyone sort of a sneak peek. We want to look at, the questions that we have. Are those the right questions? Are there questions that we have that don't matter? Are there questions that we maybe didn't think of? So please, share your thoughts on that. And then we also want to look at, are there questions that carry more weight for specific individuals? So for various etiologies of dysphagia, is this factor more important? So an example, head and neck cancer is, this aspect of BOLUS more important compared to maybe the patient that has a stroke or a TBI within the various things, general medicine, lung disease, acquired neurological progressive, head and neck cancer, structural, organ preservation. What factors are important for all of those patients in those subcategories? Do they differ? Clinically, I think most folks may say, some of those things may differ for all of those patients. So work is ongoing for that. Let's see here.
I see that one person said that maybe adding something about weight decline. We imply the framework does talk about frailty, which may or may not, may or may not implicate weight decline. Another person talked about quantifiers, And so Aaron alluded to the fact that the direction of the research, we're hoping to get funding to do exactly that, where we can go backwards and retrospectively evaluate the charts and outcomes of a bunch of people who aspirate and see if we can come up with some qualifier or quantifier that says, you know, this one has a weight of 0.1 and this one has a weight of 0.5 or whatever. And we suspect that those quantifiers may vary by medical categories, like maybe neuro patients are different than head and neck cancer patients, who are different than, I don't know, Aaron, what's another one? Like general medicine patients. So there might be, we might end up with quantifiers for specific categories, for specific medical categories, and we might end up with some questions that are just specific to medical categories. So head and neck cancer might breed a whole different or a whole additional set of questions, maybe something related to radiation side effects or something to that effect. So yeah, our goal is to establish weights for each of the questions and identify, you know, are there any questions here that we don't need? And looking to our clinical experts like you all who are sitting in the audience tonight to say, you know, what's missing here? So yes, be flexible, modify, and share. So.
I love that. There's a couple more questions here that I'll dive into some that we'll dive into. It looks like Deanna is working in home health and SNF, has to decide on thin or nectar. IV hydration isn't an option, leads towards thin because her understanding is nectar is harder to clear. Yeah, exactly. There's just some data that came out looking at mucociliary clearance for aspirated thin and thick. And thicker liquids were more difficult on the pulmonary defenses to clear out. And then there's some histological evidence out of an animal model looking at aspiration of water and then aspiration of, I believe it was xanthan gum and then cornstarch thickener. And the thickener that was instilled into the murine model lungs had a higher likelihood of histologic damage than the water aspiration. Looks like Marie has a question here about a score associated with the risk factors that could help guide a clinician to determining the degree of risk. Yeah, that's, you know, something that we've been postulating as well on making this a very clinically applicable tool. General surgery, renal medicine, all have these sort of odds of adverse outcome calculators. So you might see in the medical record, you know, someone needs operative management for some general surgery anomaly, and the general surgery folks will say, you know, given the, I can't remember the name of the score, you know, odds of adverse event are this high, 30-day mortality is this high. So definitely something that we, you know, that is top of mind there. Let's see, as we go on, what other?
Somebody mentioned adding a subcategory when I talked about perhaps modifying the BOLUS framework for different medical categories, and someone mentioned lung transplant. How many people work with transplant patients? I'm just curious, is that a lot these days, or is it, it's probably more than it was when I was younger, but yeah, it sounds like people are doing that. So somebody said they're interested in thoughts. Okay. Oh, Kendra, hi. On how this may be used alongside or instead of a mathematical model. I am not familiar with the, at least off the top of my head. Aaron, what about you? Benson and Barnes? Did we read that one?
I remember reading the paper, but I don't remember
Aspiration risk.
the methods very significantly, but a difference would be that we would use machine learning in the framework we would start with a mathematical model and then test the mathematical model with machine learning, and then as we go, that's where the weighting would come in. I don't know if that answers your question there, Dr. Grant, but we would start with is my understanding correct of that, Dr. Palmer? starting with statistical methodology and then moving it into artificial intelligence.
That's correct. Yeah, and then using an artificial intelligence model where you take your whole group, let's say you have 1,000 patients who aspirate, and you take them all and you break them into 5 subgroups of equal sizes, and then you keep testing your models and comparing the results of different groups until you, and then modify the model based on the results from the different groups, and keep remixing the patients and remixing the groups until you get consistent performance. So it's a lot of back work on trying to get the proper weighting using that approach. Yeah. Impact pre-existing CHF and or kidney issues. There were some, what was that article that talked about renal failure?
That was the Nativ, I think that was maybe Nativ Seltzer 2002. They did a retrospective analysis of I don't remember how many patients with swallowing dysfunction. It's a very good paper if anyone is interested. Very, very, very well done paper. It does look like folks work quite a bit with lung transplantation.
Yeah, that's what I was noticing. Yeah.
Jonathan Waller just had a very nice webinar on just management of swallowing dysfunction for folks post-lung transplantation over on Dysphagia Cafe. That might be helpful for folks. What
Acacia Wang just said something about choking risk being added to the framework. Can you say more about how you would define choking risk? There's also that calculator for I forget what it's called, to indicate the risk that a person will stay NPO longer and need a PEG. What's that one called?
PressCalc for post.
PressCalc. Yeah, PressCalc.
Yeah, so PressCalc is a calculator out there that may help folks. It looks like there's a question on what factors do we predict your model will determine has the largest weights to predict aspiration pneumonia. Also, will you do a model for malnutrition? You wanna field that one, Dr. Palmer, and then
Wait, I'm sorry, I was reading something. So can you repeat that, Aaron?
the summary of that is what do we think will carry the largest weight in the model?
Oh, just off the top of my head? Gosh, it's really hard to say. And because I think that it's going to vary based on medical category, I think it makes it even more of a complex question. I think that if we look back over the work from Langmore and Bach and people who've tried to play with these models before, oral care almost always comes out on top with a very clear and strong distinction among all the risk variables. So I imagine some aspect of oral health and oral care will play out to be a strong, a high weight. But I think more importantly than the weight, I think the weight will be important, but as a clinician, I think the other piece is if you check a yes to something, then asking, is it modifiable? So when you're looking at your checklist and you're saying, oh, I have this many yeses, this many nos, separating out the yeses that are modifiable and teasing those out. What can I do about those? And then what's left? And assessing the risk based on what's left and maybe the ones that can't be modified. But the other one that I'm pondering for weighting is the whole mobility thing and physical activity thing. I think that's more important than we ever realized. You know, I think back when I was a young clinician, if somebody had pneumonia, you said, you know, go lay down, right? Take a load off, relax, whatever. So now somebody has pneumonia and the goal is to get them out of bed as soon as you can, or at least get them some chest CPT or physical therapy to get their lungs moving and not let things just settle in there and let that inflammatory cycle work its way out of control into this worsening inflammation. So what thoughts do you have, Aaron, on that?
I would say the lungs would be a big one. I agree with the ones that you offered, and then I would say the lungs as well. It looks like Brian Baker shared the Native Seltzer paper there. Many thanks for that.
Thank you.
Right.
Aaron, really quick, just because we're at the 1 hour mark, if anyone needs to log off, you definitely can. But if you're wanting ASHA CEUs, just be sure to complete the survey. It's at the top of the chat. So just click on that and fill that out, and we will get you submitted for ASHA CEUs. But you don't have to stay after the hour if you need to jump off.
Thank you, Brooke. Let's see. Some folks have some questions about early mobility in the ICU. Yeah, I think that's a good point looking at that. And pulmonary medicine, you know, speech and pulmonary medicine should be like peanut butter and jelly. Just, you know, a lot of collaboration and helping each other grow as a profession. Those can be some of our best colleagues there.
So someone asked about the Press Calc. It's I think it was free app, right? I think it's a free app. I don't remember paying for it. And you put in a bunch of data points like age and and this is the Press app was written specifically for stroke patients. You put in their age and where the stroke is located and some other variables, and then it gives you two measures. It gives you a measure of the probability that oral intake is impaired and the chance that they're going to return to PO feeds within 7 days or within 30 days. And really this calculator was geared more towards neurologists so that they can estimate long-term outcomes, but it's a useful one for us to look at as well. Don't see any other, I think we fielded all of these.
And if we missed anyone's questions, you know, this discussion was so rich, everyone just, you know, sharing thoughts and asking questions. We have our emails on the handout and then also on the last slide as well. And as Brooke shared, the recording of this will be up on the TIMS website. But for anyone that has further questions, feel free to email us.
Yeah, okay. Well, thank you everyone for sharing your time and your insight. I think I got comments for adding some weight, some more specifics about malnutrition, and some support for some of the different medical categories. But if you think of something after, you know, later on tonight, tomorrow, please email us. We love to hear from everybody and share the insight of all of the clinicians that work with these kinds of patients. So thank you.
Absolutely. And just thank you guys for giving up some time on your Thursday evening. I know for our Eastern colleagues, we're out west, Dr. Palmer and I, it's pretty late for you guys, and our central colleague folks. So thank you guys for just giving up some of your evening to work on improving patient outcomes and just helping patients. So thank you guys.
Really quick, I saw a few people said that they couldn't get the link due to not being able to scroll up in the chat. I just put it in there, but I think it's getting lost again. It will be sent out via email from Zoom. And if you haven't added Zoom to your contact list in your emails, you can just find it on the TIMS website. Go to tims.com, click on resources and the TIMS University page and scroll down. When you are in the BOLUS section, the handout from Aaron and Dr. Palmer is there and the survey for completion, and it will be open for 7 days. So what's today? Thursday. So next Thursday, we'll close it in the evening and then get reporting sent over then. Thank you all very much. Have a good night.
Brooke, did you say the handout's also going to be available on your website as well?
Yes, yep. So the handout and the survey are on the website and they will be sent out via email as well. And then as soon as we log off of this webinar, I'll put the replay on the website also. So if you missed anything, you can catch it in the replay.
Thank you to Brooke and to the folks at TIMS for doing this. Appreciate it.
Yep.
Bye, everybody.
Okay, thanks. Bye. End the show.